All right, so hello, my name is Elis Lynch, and today I will be presenting my undergraduate research into the antibiotic susceptibility of Cutibacterium acnes. Before I get into the experiment that we did, I'm going to start with just a general overview of all of the players in this experiment, so you kind of know what we're working with. And then we'll get on to how the experiment was set up and what kind of results we saw from this experiment. So first, obviously, we have Cutibacterium acnes. It's a common part of the skin microflora. It's a gram-positive facultative anaerobe, so it prefers anaerobic environments over aerobic environments, but it can grow in both. It lives in the sebaceous glands on the surface of the skin, and it tends to feed on sebum, which is why we see kind of an uptick with the onset of puberty in most people, because as you get a higher level of pubescent hormones in your system, you get an uptick in sebum production, leading to an uptick in the bacterium. It plays a really major role in kind of maintaining the homeostasis of the skin and acts as kind of a barrier to invasive pathogens, so they can't get into your pores and create infections. Unfortunately, sometimes pores get blocked, and when pores get blocked, you get less oxygen in that area, and with less oxygen, the organism tends to grow a little bit better because it prefers oxygen poor environments. That's why it's called an anaerobe. And so because of this, we can see an overgrowth of Cutibacterium acnes, resulting in what we all know as pimples and acne. Um, it can progress to severe acne in the form of acne vulgaris, which is more of a skin infection. It's not just Cutibacterium that you're going to find in the case of acne vulgaris. You're going to find other staph that typically live on the skin when you have that kind of situation. We're going to go into antibiotic resistance, which is super interesting in Cutibacterium acnes because prior to 1976, we actually don't see much in the way of antibiotic resistance. We started seeing an uptick of resistance in Cutibacterium acnes between the years of 1976 and 1978, when studies in a meta-analysis by Walsh et al. Shows that about 20% of samples taken from just people on the street who signed up for the studies were showing resistance to commonly used antibiotics for acne treatments. These antibiotics being erythromycin, clindamycin, and tetracycline. Um, it's largely a consequence of the overuse of oral antibiotics in the treatment of acne. Most people are going to experience acne in their lives, and if you prescribe antibiotics for every single case of acne, you're going to end up with antibiotic resistance. In Cutibacterium acnes, this kind of comes through the use of plasmids and transposons at the points 23S and 16S on the rRNA genes, which result in different alterations of protein binding sites, which kind of blocks the ability of an antibiotic to bind and do its job to kill the organism. In this study, we looked at some antibiotics that are derived from antibiotics that Cutibacterium acnes is already showing resistance to in most of these studies. And today, even as of 2015, when the meta-analysis by Welsh et al. Was kind of compiled and put together, we're still seeing about 50% of samples showing resistance to the three major antibiotics that have been tested on Cutibacterium acnes. Which brings us around to our first antibiotic, doxycycline. Doxycycline is a semi-synthetic derivative of tetracycline. The advantage of using doxycycline over tetracycline is that it's just more easily absorbed into the body and has a longer half-life than tetracycline, resulting in a lower overall dosage of the drug during the course of treatment. It's also found to have a brighter range of effectiveness against microorganisms when compared to tetracycline. Doxycycline works by binding to the 30RS ribosomal subunit and inhibiting the action of amino acyl tRNA, which prevents the synthesis of polypeptides. And if you can't make polypeptides, you can't make an organism. So it results in the inhibition or death of the organism. Next up, we have azithromycin. This was the second antibiotic we looked at in this study. It is a semi-synthetic derivative of erythromycin. It has, much like the benefits in doxycycline, azithromycin has the benefit of having a longer half-life and a broader range of effectiveness than its parent antibiotic. It also has the benefit of not being as unstable in acidic environments when compared to erythromycin. So erythromycin requires an acid-resistant coating in order to survive the acidic environment of the stomach in order to be effective in treating bacterial infections. And azithromycin just doesn't meet that, which is obviously a pretty big benefit when you're talking about synthesizing this antibiotic. Azithromycin works in a lot of the same way as doxycycline. It binds to the 50S subunit of the ribosome, also preventing the production of polypeptides and resulting in inhibition or death of the microorganism. And our third antibiotic is trimethoprim. Trimethoprim is the only fully synthetic antibiotic we looked at in this experiment, and it's a derivative of sulfonamide, which is one of the bigger classes of fully synthetic antibiotics that we have. It's also one of the oldest classes of synthetic antibiotics that we have. Trimethoprim is preferred over other sulfur drugs because it has a higher level of effectiveness and a lower level of side effects when compared to other drugs in its class. Trimethoprim works a little bit differently compared to the other antibiotics in the study. So as opposed to blocking the formation of polypeptides, trimethoprim will bind to folate reductase, resulting in an inability for the microorganism to use folate to make folic acid. Unfortunately, this also creates a side effect in the patient. They will also experience lower levels of folic acid in their blood serum because trimethoprim has the ability to bind to the microorganism, but it also has the ability to bind to mammalian cells. So when you're treating someone with trimethoprim, that's something that needs to be considered. So on to the experiment, the fun part. We did 2 trials of this experiment. In both trials, we took 15 blood agar plates and inoculated them using sterile technique and kind of the lawn method. So we took a glass stir rod and put a drop of inoculated fluid onto the plate, stirred it around to create a lawn of bacterium. On each of these 15 plates, they were divided. There were 5 antibiotic test strips from each of the tested antibiotics, that being azithromycin, doxycycline, and trimethoprim. 5 replicates were made for each. And then an additional 5 plates in each trial, resulting in 20 plates per trial, were left fully uninoculated, fully unopened for controls. We then took all of our plates, put them in a little anaerobic incubation chamber, and incubated them at 30 degrees Celsius for about 5 days, which is a little bit longer than you would normally incubate bacteria when looking at this specific experiment. Normally it would be 48 to 72 hours, but Cutibacterium acnes is a little slow growing. So we found that the 5 days was kind of optimal to see good growth on the plates. Results were taken by measuring the zone of inhibition, using image J and statistical analysis to see kind of where we were at as far as the resistance that the organism was showing against the drug that was being tested. The minimum concentration of antibiotic at the first sign of bacterial inhibition was found using the concentration tick marks that are available on the test strips that we used. What these tick marks are is essentially as you move further away from the middle of the strip, you have lower doses of the antibiotic. So you look at where the field of bacteria kind of crosses over the strip, and that's where you're going to find your minimum concentration of the antibiotic, where it is creating resistance against the bacterium. For azithromycin, we found that the average concentration was about 0.1004 micrograms per milliliter. Doxycycline, the zone of inhibition started at 0.0517 micrograms per milliliter, and Trimethoprim, the average concentration was 1.25 micrograms per milliliter, and this can all be seen in the lovely table that's available here on the side. The MIC guidelines for these antibiotics were what we used to test and see if the microorganism was resistant. So if the microorganism shows an MIC level of 90, so that means that 90% of the organism is being killed at this rate. We say that the organism is sensitive there. We say the organism is resistant when only 50% of the organism is being killed. And these can also be seen in the chart, these kind of MIC guideline labels. And through the analysis of our results that we found, we concluded that C. acnes was showing resistance to trimethoprim and some sensitivity to azithromycin and doxycycline. Azithromycin and doxycycline are both antibiotic resistance or derivatives of antibiotics that are already showing resistance to C. acnes. So them kind of being kind of in this middle ground between resistance and sensitivity makes a little bit of sense because most of the population, about 50% of the population actually being found for Cutibacterium acnes is already finding resistance against an antibiotic that's very closely related to these two. So the fact that they're not fully sensitive but not fully resistant could be a sign that there's just kind of a muddy area where the organisms is showing a little pushback, but it can't fully push back against that antibiotic. Now, trimethoprim was interesting. And through a little bit more research, I found that folic acid is commonly used in the treatment of acne vulgaris. So trimethoprim doing the exact opposite, as opposed to bringing folic acid into the organism, it is preventing the use of folic acid in the organism by preventing folate reductase. So it could be that trimethoprim is doing the exact opposite of what we're wanting to do, where it's making where it might be more beneficial for the organism to be in an environment with trimethoprim. But more research is going to have to be done into that to see if that's what's going on, or if there's some other reason that the trimethoprim just isn't working for that organism. And that's it. That's the end of it. Thank you, and have a nice day.